Hi everyone, my name is Krista Mater, and Dr. Chris Ray and I completed a systematic review of interventions to improve gait asymmetries. Gait asymmetries arise from a variety of musculoskeletal and neurological diseases, as well as pain. The video represents a circumduction gait frequently seen in stroke survivors. Often in adults, gait asymmetries result from stroke, Parkinson's disease, amputations such as trauma or from diseases like diabetes, and other injuries. A few of the most common methods to correct gait asymmetries are using the split belt treadmill, orthoses, and weight shift training. However, methods are not clear in this population nor their effectiveness. This brings us to the purpose of this systematic review was to examine the current non-invasive and non-pharmacological methods used to reduce gait asymmetries. For this systematic review, the databases used were Sportdiscus, PsycInfo, and PubMed. Our search algorithm was gait, ambulation, walking, mobility, locomotor, or locomotion, and symmetry, asymmetry, symmetries, asymmetries, symmetrical, or asymmetrical. We refined our search by papers in English that were peer-reviewed and published between 2009 and 2019. This search results in 320 articles found. After removing duplicate articles, we were left with 229 articles. We screened the 229 articles and focused on adults, lower extremity motion, and asymmetrical gait. So 111 articles were excluded due to non-full text, upper extremity motion, children, prosthetics, surgery, and non-gait asymmetries. This results in 118 full-text articles to assess for eligibility. We also focused on a direct intervention to correct the gait asymmetries. So 92 articles were excluded if they had no direct intervention. And this left us with 26 studies included in our systematic review. Of the 26 studies found, the most common population was stroke survivors in 19 of the studies. Parkinson's disease individuals were in 3 of the studies. 22 of the studies had sample sizes of 30 or less. To assess the gait asymmetries, in 12 studies they used motion capture, and in 6 different studies they used gait right or force plates, and 4 studies used EMG. The methods to correct the gait asymmetries, there were 5 using orthoses or insoles, 4 using split belt treadmills or weight shift training, 3 used resistance mechanisms, and 2 used auditory cues. The duration of the training ranges from 1 session up to 12 weeks. The gait asymmetries were quantified by spatial and temporal asymmetry parameters such as step length in 21 of the studies, swing and stance phase duration in 15 of the studies. In 5 studies they had ground reaction force, and in 4 of the studies they used single leg support time to quantify the asymmetries. At least one asymmetrical gait variable improved after interventions in 21 of the studies. In the 26 studies, we saw a range of methods used. Intervention time and durations varied. There were fairly small sample sizes, and the populations were mainly individuals with a history of stroke or Parkinson's disease. And in this review, we noticed a lack of virtual reality studies. So in the future, we need to link specific gait asymmetry metrics to functional outcomes and/or fall risks, and explore frequency, intensity, and duration of various intervention strategies, such as using virtual reality to achieve optimal gait symmetry. Here is my contact information. Thank you all for listening.